participants to join. I am Dr. Hania Zara. Hello, everyone. I'm Dr. Hania Zara, AMC mentor from MedPrepOnline. And today, our webinar topic would be CTGs, X-rays, and ECGs that are commonly tested in the AMC MCQ exam. And we will first start with the CTGs. And I will tell you the interpretation of the CTGs, how you interpret them, and how you solve the questions of CTGs. We won't solve the questions exactly, but I will tell you how questions will be asked from which aspects. And then we will do the common X-rays and ECGs. I have taken the X-rays and ECGs from your handbook. That will be very helpful for you to review afterwards. Almost all of the X-rays and ECGs are from your handbook. And let's start with the CTGs first. Okay, what exactly is a CTG? CTG is basically cardiotogography, just like ECG. ECG is the graphical representation of the electrical activity of heart. Just like that, cardiotogography records the fetal heart rate and the uterine contraction simultaneously, and then gives us a graphical representation of it. And what's the purpose of CTG? It basically detects the fetal distress and it guides in the clinical decision of ops and of gynae ops. Basically, we will first start with the definitions, basic definitions that you should know in a CTG. The first one would be the basal fetal heart rate. The baseline or basal fetal heart rate is basically the mean level of the fetal heart rate, which is without any acceleration or without any deceleration, and it is the mean. It is the constant or the average fetal heart rate, basically. So if we see here, one box represents 1 minute in this CTG graph. And if you see for this instant, for this minute, you see that the fetal heart rate is about 150 beats per minute. And is in this instant, it is about 130 beats per minute. So on average, if you make a line here, you see that the average fetal heart rate is about 120 beats per minute. So this is the baseline fetal heart rate. The normal baseline fetal heart rate would constitute from somewhere between 110 to 160 beats per minute. And if it is less than 110, it is fetal bradycardia. And if it is more than 160 beats per minute, then it is fetal tachycardia. Now, after the baseline fetal heart rate, we come to the baseline variability. These are basically the minor fluctuations in the fetal heart rate. For example, let's take this instance. In this particular minute, the fetal heart rate was about 150 beats per minute, and then it fell to about 130 beats per minute. So this variability, this up and down of the fetal heart rate is basically the variability of the baseline variability of the fetal heart rate. And it is normal to have baseline variability of about 6 to 25 beats per minute at the baseline fetal heart rate. And if it is about 3 to 5 beats per minute, you will call it reduced fetal variability, fetal heart rate variability. See, for instance, in this, you see that the variability has been reduced and there is no variability of more than 3 to 5 beats per minute. And this is also kind of normal in if a fetus is sleeping, but if it is not normal if it's more than 40 minutes. If it is more than 40 minutes, the recording is of this reduced variability, then it is not normal. Then it indicates a whole lot of causes. For example, if there is any CNS injury of the fetus, or the mother is using any drugs, for example, any opioids, any benzodiazepines, or there is severe fetal anemia, or there is fetal CNS injury, then the baseline variability would be reduced. And we will call it absent baseline variability if it is less than 3 beats per minute. And if it is more than 25 beats per minute, then we will call it increased baseline variability. Okay, then there is sinusoidal pattern. Sinusoidal pattern is a very lethal pattern, to be very honest. These are just regular oscillations of the fetal heart rate. There are no accelerations, no decelerations, no fetal baseline heart rate, just sign pattern. And this indicates, sorry, severe fetal anemia, or it can indicate fetal intracranial bleed or fetal hypoxia. So this requires immediate urgent delivery of the fetus, or you can just lose the baby in seconds. Okay, now coming to the accelerations. Accelerations are basically transient increases in the fetal heart rate for more than 15 beats per minute, and they remain for like more than 15 seconds. And two or more in a 20-minute CTG recording is normal, and this indicates that the fetus is healthy and it is moving basically. If there are no accelerations in any CTG, it does not signify anything. But if we have accelerations in CTG, then it is a good sign. Now coming to the decelerations, like the accelerations, the decelerations are decreases in the fetal heart rate of more than 15 beats per minute and for more than 15 seconds. Okay, now there are many different types of decelerations. Uh, Starting with the early decelerations, these are uniform repetitive decreases in the fetal heart rate that starts with the uterine contractions. Okay, this is the pattern of the uterine contraction. You can see that the deceleration has started with the uterine contraction. It is coinciding with the uterine contraction and it is ending with the uterine contraction. So it means that these are early decelerations, and this is a cause of fetal head compression. Whenever the fetal head is compressed, we get early decelerations in the CTG. And we also get variable decels that do not coincide with the uterine contraction. Like in this one, you can see that it does not coincide with the uterine contraction and it occurs independently. What are the causes of variable D cells? There are many causes, but two most important causes are umbilical cord compression and cord prolapse. And if any of these things are added to the variable D cells, we call it complicated variable D cells. What are the fourth additional things if added to the variable D cells we call complicated variable D cells? They are the rising baseline rate or fetal tachycardia, reducing baseline variability, slow return to baseline fetal heart rate after the end of contraction, or either the amplitude is very large or of a very long duration. Then we call them complicated variable decelerations. Okay, then we have prolonged decelerations. These are a fall in basal fetal heart rate for more than 90 seconds, and it can go up to 5 minutes. And if it lasts more than 5 minutes, we will definitely call it fetal bradycardia. But if it is more than 90 and up to 5 minutes, we call it prolonged decelerations. This is the pattern of prolonged decelerations you can see. And the causes of prolonged deceleration would be maternal hypotension or umbilical cord prolapse or uterine hyperstimulation or prolonged uterine contraction or maternal seizures or fetal hypoxia. Uh, the last one is the late deceleration. In the late deceleration, the decel starts from, I'm sorry, the decel starts from the between in mid of the contraction, and then it ends after the contraction ends. And this is a sign of placental insufficiency. And all the causes that I'm stating here of the different causes of these decels, either it's prolonged or it is late or it is variable, the causes are reversible. Okay, now we have I have made a very crisp summarized table for you guys, and if you guys will learn just this table for your exam, it will be very helpful for you to solve any question of CTG. Okay, I have uh, taken this information from the RANS OG guidelines of Australian official obstetric and gynecological guidelines that they follow. And I have summarized it in a table form for you guys to review afterwards and revise quickly. And this table comprises of the fetal heart rate, baseline variability, uh, deceleration and acceleration. It will tell us whether it is of normal range, whether it is occurring in isolation. When any of these occurs in isolation, it doesn't mean that the fetal is compromised. If any one of these is present in the excuse me, just give me 2 minutes. Okay. If any one of this is present in the CTG, then it requires further action. And if any one of this is present in the CTG, then it definitely tells us that the fetus is compromised, and we need to have urgent management and urgent delivery of the baby. Okay, what are the normal things in a CTG that we consider normal and then no further action is required? Fetal heart rate, as I told you already, that it will be between 110 to 160 beats per minute. Baseline variability will be 6 to 25, and decels, there will be no decels, and acceleration 2 in 20 minutes. Then no further action is required for this kind of CTG. And if any one of this is present, then you just observe the patient. You just do continuous CTGs and you just observe the patient. For example, reducing or reduced baseline variability is found in any patient. This is also found in a fetus that is sleeping. So you just observe the patient. But if two or more is present in a CTG, then you may require further action. What further actions, that I will tell you in the next slide, but you just have to understand what this table means. If two or more are present in a CTG, then you will definitely intervene and do the management of the patient. And if any one of this is present in a CTG, then you definitely have to manage the patient. For example, complicated variable D cells are present in any CTG, then you have to intervene. And any one of this, if it is present, for example, sinusoidal pattern is present in any CTG, then you have to go for urgent delivery of the patient. So if you just learn this table, it will be very easy for you to solve any question of CTG in the upcoming exam. Okay, what further actions you will take? You will do the fetal blood sampling. Fetal blood sampling is of two types. One is the scalp lactate and the other is the scalp pH. You will take the sample and assess for the pH and lactate of the fetus. If the pH is less than 7.21 or the lactate is more than 4.21, then immediate delivery by C-section or assisted vaginal delivery is required. And you have to go for urgent delivery if there is clear evidence of serious fetal compromise, either by fetal heart rate pattern that I've told you in sinusoidal pattern. You have to go for delivery immediately. For example, there are clinical concerns, there is any placental abruption, there is any maternal or fetal sepsis, then you have to go for immediate delivery. In this context, you do not do fetal blood samplings because it delays delivery. There is any CTG abnormality that requires further assessment, but the fetal blood sampling is contraindicated. What are the contraindications of fetal blood sampling, that I will tell you in the next slide. But if there is any CTG abnormality and fetal blood sampling is contraindicated, you will definitely go for immediate delivery. And if the decision to delivery interval is prolonged, then you will definitely go for immediate delivery because it will compromise your patient. Okay, what are the contraindications to the fetal blood sampling? There is evidence of serious sustained fetal compromise. For example, there is any abnormality in the CTG. For example, any sinusoidal pattern, any complicated variable D cells, prolonged D cells, then you will not go for fetal blood sampling. Instead, you will go for urgent delivery. There is risk of fetal bleeding disorders like fetal thrombocytopenia or hemophilia. There is non-vertex position. Okay, about the positions, there are like breech positions. There is mobile presenting part, or unengaged head or non-dilated cervix. Then you will definitely not do fetal blood sampling. There is any maternal infection, you will not do fetal blood sampling, because obviously it will infect the fetus as well. It will have a chance of infecting the fetus as well. If the gestational age is less than 34 weeks, you will not do fetal blood sampling. If there are prolonged decelerations, you would not go for fetal blood sampling. And there is advanced or fast stage labor, then also you won't go for the fetal blood sampling. Instead, you will just do the urgent vaginal assisted delivery, or just go for the immediate cesarean section. Okay, about the management, if you require immediate management, you will first call for assistant or call your senior. You will identify the cause and treat it. I've listed many causes of the D cells that in the previous slides. You will just identify the cause and you will treat it. If the patient has hypoxia, you will definitely give oxygen via face mask. If she is having fever, you will give paracetamol. You will reposition her in the left lateral position, and you will definitely avoid supine position, because in supine position, the great vessels are compromised, and maternal hypoxia can cause fetal hypoxia, and in turn, bad CTG. You will check the maternal BP and give her IV fluids. If she is hypotensive, you will discontinue oxytocin and decrease the infusion rate, because uterine hyperstimulation can also cause prolonged decels. If indicated, you will perform vaginal exam to exclude the cord prolapse, because it's also a cause of bad CTG. You will consider fetal scalp sampling if it is not contraindicated. You will prepare for assisted delivery or immediately emergency C-section in case of contraindication to fetal blood sampling. Okay, that was all about CTGs. This is the uh, in-depth explanation of the CTGs that I've told you. And in the further classes, we will solve questions too about CTGs. It was just an introductory class, but in the upcoming classes, we will solve questions as well. Okay, now starting with the x-rays. For the x-rays, you need to first know what a normal x-ray is and how to read a normal x-ray. The first thing you do, you will confirm the if you are reading the correct patient's x-ray or not. You will confirm the patient's age, name, and date, and it is good to always compare with the previous x-rays that a patient is having. And then you will start with the ABCDE approach. uh, A is for airway. You will see the trachea, if it is midline or not, if it is deviated or not. Then you will see the bronchus, if there is any foreign body or masses in it. Then breathing. In breathing, you will see the lung fields and the pleura. If there is any consolidation, any pneumothorax, any mass, or you will compare the right and the left lung, and you will also see if there is any collapse or blunting of angle. This is the claustrophrenic angle. If there is any blunting, then you will see if it's any pleural effusion or not. Then after B, you will see the C. C is circulation. You will see the heart, and you will see the mediastinum, if there is any mediastinal widening or not. And you will see the great vessels, the contour of it, and you will see the heart size, if it's normal or you are having any cardiomegaly. Then you will see the diaphragm, D for diaphragm. You will see any free gas under diaphragm. That is very, very common in perforated peptic ulcer disease, and that is a very frequently tested topic as well. And you will also see if it is flattened in COPD. COPD is also very frequently tested. And then you will see everything else. E is for everything else. You will see the bones, you will see the soft tissues, and any other finding significant. For example, and anyone is having pacemaker or tubings, you will just see that in the end. Okay, these are the x-rays from your handbook that I've taken. So I'm giving you like 30 seconds to write down in the chat box what are your findings in this X-ray. Then I will tell you the answer. Yes, you guys are right. There is a gas under diaphragm, and yes, it is air under diaphragm, and it is very common in POD perforation, and it is a very frequently tested topic as well. You can see subdiaphragmatic gas from the peptic ulcer disease perforation. Okay, now moving on to the next X-ray. What do you guys see in this one? Yes, you guys are right. This is right upper lobe pneumonia. You can see the opacity here. And you guys also see the rounded opacities of the bilateral prosthetic breast implants, but these are not significant. This is significant finding in this X-ray. These are from your handbooks. You should definitely go and have a look in your handbook that how the cases are given in the handbook, how the X-rays are given and how are they asked in the handbook. Can anyone comment on this one? Yes, Dr. Ali, it is sigmoid volvulus, basically large bowel obstruction. This is a very, very, very frequently asked question in the exam, and it is a typical coffee bean sign, inverted coffee bean sign. You can see this is the sigmoid volvulus, this one. And the patient is always a resident of old age home care, old man presenting with vomiting and lethargy and dehydration. So this is how the case presents, and this is the X-ray they always give. Moving on to the next one. Can anyone comment on this one? Yes, this is typical of aortic dissection. You can see the mediastinal widening in this one. It is the widened upper mediastinum on chest X-ray, aortic dissection. And the patient always is a hypertensive lady or a hypertensive man, or maybe having Marfan syndrome. Now moving on to the next one. Okay, this one is a right upper lobe pneumonia. You can see the consolidation in the right upper lobe. Moving on to the next one. Can anyone tell what this is? No, in CMETs, there will be many cavities, like many big cavities, and like it's like cannonball appearance. But this is a single cavity that is more giving us the diagnosis of tuberculosis. This is left apical tuberculosis. This one. A single cavity is until proven otherwise a tuberculosis. If there are many cavities, many canal wall cavities, then it will be CMS. This one. Can anyone tell what this one is? This one is a little bit difficult, but you can see teeth here. Is it a usual place to have teeth here? This is ovarian dermoid cyst. In dermoid cyst, you can have any organ from any cell line. So this presented as a teeth hair, ovarian dermoid cyst. This one is a very pretty interesting case. This is in your handbook. Okay, now we have finished the X-ray part. These are all the X-rays from your handbook. I've taken majority of the chest X-rays and two of the abdominal X-rays. And I would suggest you guys to go and have a look at the cases that they have given these X-rays with, and it will be of a good practice. And if you guys will just go through the slides again, it will refresh your memory. Now coming on to the ECGs. I know ECGs are a very difficult topic for every medical student and every doctor. And every time a ECG pops up, you are like, "Okay, oh my God, what is this?" But I have made it as simple as possible for you guys and for myself. Uh, Look at how to interpret an ECG. Basically, what I do is first of all look at the rate of the ECG, then I look at the rhythm, then I look whether it has P waves or not, then I look at the PR interval, then QRS complex, then ST segments, and then the T waves. If you go systematically like this, you will never miss anything in ECG. Uh, for example, the rate. How will you calculate the rate? You will uh, see 2 hour intervals. For example, you look at this one, you will see how many boxes are there in between them. For example, 1, 2, 3, 4, and 4.5, almost 5 boxes here are here. You will divide 300 by the number of large boxes. 300 divided by 5 would be 60. So heart rate would be 60 here, okay? Then you will see the rhythm of the ECG. You will see if the RR intervals are equally spaced or not. If they are equally spaced, it is a regular rhythm. If they are not equally spaced, they are irregular rhythm. Then you will see the P waves. If the P waves are present or not. I can see P waves here, everywhere, okay? So it is a sinus rhythm. P waves are present. Then you will see the PR interval. To make it easier for me, I've learned that the PR interval are 4 small boxes. So 4 small boxes. If it is more than four small boxes, then the PR interval is definitely prolonged. Then QRS complex, these are roughly 2 to 2.5 boxes, small boxes. If it exceeds from more than 2.5 boxes, then it is definitely widened. Then you see the ST segments, whether they are depressed or elevated, as in the STEMI or NSTEMI. And then in the end, you see the T waves. Either they are inverted or not, or they are tall peaked, like in hyperkalemia. Okay, the ECGs that I have taken are from the handbook as well, and more or less they repeat the same ECGs. I'm so sorry. More or less they repeat the same ECGs. In my exam, I had AFib ECG, and I also had a first degree AV block. Uh, the first degree AV block ECG was just the identification ECG. They were just like identify this pattern. But the AFib, they were asking about the management as well. So the question comes in two forms. Either they just ask for the identification of the ECG rhythm strip, or they ask for the management. Most commonly, the AFib management is very important and will be taught to you guys in the upcoming classes. But for this class, for my class, the main purpose is for you guys to identify the rhythm of the ECGs, commonly asked ECGs. So can anyone tell what is this ECG pattern? Yes, you guys are right. This is ventricular tachycardia. There is a small, short period of sinus rhythm followed by ventricular tachycardia. You can see widening of QRS complexes and haphazard waves. And this is typical of ventricular tachycardia. Please get yourself familiarized with these rhythms, because they do ask questions about the management of ventricular tachycardia and VFib as well, when to give DFib and when to start CPR and everything. You need to familiarize yourself with the patterns. Can anyone tell me what this ECG is telling us? Yes, this is AFib. How is this AFib? You can see that the intervals between RR complexes are not equal. For example, in this instant, it is 1, 2, 3, 4, 5. Around 5 large boxes, and in here it is only 2.5 boxes, in here it's 3 boxes. So the rhythm is not regular. Also, the P waves are absent in this. So this is typical ECG of atrial fibrillation, and this was in my exam as well. I had the same ECG in my exam, and they asked about the management of the AFib. So get yourself familiarized with this one especially. Okay, moving on to the next one. Yes, this is atrial flutter. This is typical sawtooth appearance. This is sawtooth appearance of the atrial flutter. And this is not frequently tested, but it does come in the exam every now and then. But AFib is very frequently tested in ventricular tachycardia as well. Moving on to the next one. And this is most probably the last ECG of today's session. Yes, everyone is right. This is supraventricular tachycardia. Why is this supraventricular tachycardia? Because the heart rate, you can see between two RR intervals, we have two large boxes. So the heart rate is around 150 beats per minute, and there are no P waves. These are T waves, not P waves, okay? So there is no P wave, and this is definitely supraventricular tachycardia. Okay, the references I used for today's class were your very famous AMC handbook, and I would definitely recommend you guys to go through those X-rays and ECGs from your handbook, so that I've just taught you guys, and when you will go through the cases, it will be very easy for you guys to pick. And I've given you the link of the RANS OG guideline of the Australian guideline that I've taken the CTG information from. The definitions are definitely from these guidelines, and the CTG images were from the Geeky Medics, how to read CTG. This is also a very good read if you guys want it in a very simpler language. You can just go and visit this one. I hope Hala will give you guys this presentation, and then you guys will be able to just click on it, and you will open the link for yourself. Yes, I will ask my team to get the presentation to you guys. Okay, any questions? I think nobody has any questions. So uh, thank you everyone for having the session with MedPrep Online and me. And I'm very hopeful to see you guys again in the next session. And have a nice day and take care.